presentation is acute abdominal pain leading to paraganglioma diagnosis. In this presentation, I have a patient. He's 64-year-old male, no significant past medical history, that presented to the hospital with a 3-day history of right lower quadrant abdominal pain that radiated to the groin. This pain was not associated with any other symptoms, and it was unrelated to heavy lifting. He did not have any relief with medications that he was taking at home, and while he was lying prone, exacerbated the pain. He had this discomfort in the past that it wasn't as bad as it was on this admission, and he related this discomfort to a hernia that he has been diagnosed with a couple of years before. Physical exam, remarkable for hypertension in 163/95, and he had significant tenderness with deep palpation of the right lower quadrant. On palpation of his abdomen, there were no masses palpated. He just was in significant pain. His blood work was completely unremarkable, but a CT scan of the abdomen and pelvis revealed side height, right-sided hydronephrosis, and a 5.1 by 4.5 centimeters retroperitoneal calcified mass that was noted to be at the aortic bifurcation. In this first picture that I have here, we can see how the mass has some calcifications inside. It's more closely to the right kidney. And the second picture, it's like the standing picture, and you can see how it is coming out of the aortic bifurcation. This was very concerning given his age and the size of the mass for a malignancy. So oncology was consulted with recommendations to perform a biopsy. That biopsy was very difficult for surgery. So he, for interventional radiology, to get to given the location and the closeness to the aorta. So he had to undergo with general surgery a diagnostic laparoscopy that subsequently core needle biopsy had to be performed. So after 2 days, the pathology came back positive for sclerotic stroma with encased epithelioid cells and a foamy cytoplasm. Immunohistochemistry was positive for synaptophysin, and surrounding cells around it were positive for S100. All of this together, consistent with the immunohistochemistry, was consistent with a paraganglioma diagnosis. He did not undergo catecholamine testing while he was in the hospital, but he was eventually discharged with close follow-up with surgery and oncology. This case is interesting because we often don't see paragangliomas, and these are rare neuroendocrine tumors that are derived from the extra-adrenal chromaffin cells. And we usually see this more related to pheochromocytomas, and this is the first disease that comes to mind when you have someone that is hypertensive, tachycardic, and has this type of cells on pathology. This paraganglioma is usually in the head and neck, and it can present even in the skull and the bladder, which is where his was close to. Usually it presents in 0.8 per 100,000 persons per year, and the majority of them are benign, but usually they can be malignancy. So treatment is surgical resection of the mass, and he was discharged with a referral to surgical oncology upon discharge. Thank you.
So were catecholamine levels subsequently obtained? And if so, what were the results?
Yes, so they were obtained and they were positive. He followed up with oncology, and they said that this is often, on their note, they said that this is often very similar to the pheochromocytoma. And the only way of knowing for sure one or the other was the biopsy. So because he had already had the biopsy, they were very sure that this was more a paraganglioma rather than a pheochromocytoma. And he is scheduled for having that resected at that time.
All right. Thank you very much.
Thank you.